Welcome to the Psychexperience.
Hello everyone and welcome to the Psychexperience. I am Dr. Nardi. I have Pedro here with me, and today we're going to talk to Sami Timimi. Dr. Timimi is a consultant child and adolescent psychiatrist in the National Health Service in Lincolnshire and a visiting professor of child psychiatry and mental health improvement at the University of Lincoln in the UK. He writes from a critical psychiatry perspective on topics relating to mental health in childhood and has published over 130 articles and tens of chapters on many subjects, including childhood, therapy, mental health services, and culture. He has authored 6 books, including Naughty Boys, Antisocial Behavior, ADHD and the Role of Culture, co-edited 4 books, including with Jonathan Leo, Rethinking ADHD, From Brain to Culture, and co-authored 2 others, including with Neil Gardner and Brian McCabe, The Myth of Autism, Medicalizing Men's and Boys' Social and Emotional Competence. His latest book, Insane Medicine, How the Mental Health Industry Creates Damaging Treatment Traps and How You Can Escape Them, is available in a serialized form on the Mad in America website, as well as for purchase from Amazon, where I got the book, and has been very enriching reading and very mind-opening. So, Dr. Timimi, Sami, thank you for accepting our invitation.
Well, thank you very much for inviting me, Rod.
Well, I reached you initially because, I don't know how the UK is doing, but in America, we have an army of kids taking antipsychotics and things and all kinds of medications in high doses and being exposed to all kinds of side effects. And I reached you to talk about that. And as I'm reaching you and I'm looking for your literary production, I should say, and I found the Insane Medicine book and I started to read it and it kind of blew my mind, and I said, okay, I actually have to cover this thing first. So I'm very happy to be finally asking these questions for you. But I wanted to start with asking you, why do you believe that, technically speaking, there's no such a thing as a psychiatric diagnosis? Can you elaborate on that for us?
Yeah, I think when you understand this, a lot of the other things that I've been proposing and the other conclusions that I come to all start to fit in, because I think this is a kind of a foundational assumption on which we've built a whole system for understanding the sorts of presentations that come to us as psychiatrists. So it goes back to the starting point being thinking about what is a diagnosis? What sort of system of classification does a diagnosis represent? Well, a diagnosis is a particular type of classification system, one that's based on an implication or an understanding of what the proximal cause might be. That's the way it's developed in medicine. You can further understand what's sitting behind that if you think about a few simple presentations. For example, if I go to the doctor and I have had a cough that won't go away for a week or so, what I expect the doctor to be doing is to elucidate what the possible causes might be, or the proximal causes of that cough. There will be a number of things that they can do which is external to their subjective opinions. They still have to interpret this, but they can listen to my chest, could take a peak flow reading, could decide that maybe I need an X-ray or a sputum sample, and so on and so forth, because understanding what might be the proximal cause of my cough is going to have a big effect on what might be the appropriate treatment. If the cause of my cough might be some sort of allergic or asthma type presentation, and you're going to treat it with steroids, you wouldn't do that if you had an infection, because your infection may get worse with steroids. So it really matters understanding the proximal cause. And that's what we go to the doctor for. You know, if I have a chest pain, I want to know what's causing my chest pain. I'll be relieved if they say it's something to do with an acid reflux, and because my concern might be maybe it's something to do with my heart. So our system of classification that we call diagnosis is a system that, technically speaking, is based on an understanding of a proximal cause. And we think of diagnosis not just in terms of medicine, but you can find this in engineering. If you took your car to a garage, at least in the UK, and you've got something going on that you don't understand, you know, some gremlin in the software, and lights turn on and you don't know why it's doing that, and there's some rattling under the hood. Car mechanics may say that they're going to run some diagnostics. They do that in computer programs, yeah? I don't know if it's the same you're based in the US, is that?
Yes. It's about the same, yeah.
So that's what a diagnostic assessment is. That's what a diagnosis is. It refers to a proximal cause. Of course, you know, there might be all sorts of other things going on. So we know that diabetes is something that is a diagnosis to do with your blood sugar being too high, but we might not understand yet why the reasons for some people getting so secondary causes, or more distal causes, if you like. However, if you have a proximal cause, you can now start building, you have a basis, if you like, you have some empirical anchors from which you can start building systems of knowledge. You can start investigating factors that might be associated. You can start looking at timeline. You can start looking at outcomes of different treatments. You can start subdividing different, and there may be all sorts of debates around the boundaries of when is blood sugar too high. When should you call it diabetes as opposed to pre-diabetes or not diabetes? At what point should you go from using dietary management to using medication? You can have all of these different debates, and they do go on across medicine, because the way I think about medicine in general, I think of it as a craft that is informed by scientific principles. But of course, medical practice has all sorts of dimensions. We get very caught up in the whole technical aspects of medical care. But the clue that there are other things to do with medical care is in the word care, because it is a human social relational activity, dealing with suffering, looking after patients, thinking about chronic presentations and all the ramifications on the psychosocial. So it's not that the rest of medicine diagnosis is sufficient, but at least the diagnostic bit allows for the building of a technical framework of knowledge based on an understanding of proximal cause. And that's what a system of classification by diagnosis is. Now, if we compare that to psychiatry, we start to see how we fall short. But it's not just that we fall short, but when we use the language and concepts of diagnosis, we start committing what philosophers would call a tautology. We start falling into circular thinking traps. So let me give you an example or a comparison. If you take the definition of diabetes, as I said, it has an empirical anchor external to the subjectivity of the person doing the diagnosis. So it's defined by reference to your blood sugar being considered to be pathologically too high. But you can measure blood sugar. You can measure blood sugar, you can measure fasting blood sugar. You can also measure other things like sugar in the urine, proteins in the urine. And and so on. So you have an empirical anchor external to the subjectivity of the person doing the diagnosis. And so that is reflected in its definition. But let me try and define something like attention deficit hyperactivity disorder. The only way I can define hyperactivity disorder is by describing it. So it is the presence of levels of inattention and hyperactivity and impulsivity that's considered to be developmentally abnormal. Now, the entirety of that is subjective, and it's actually not referring to any proximal cause, even though we've decided to imagine it as a neurodevelopmental condition. But there's no neuro measurement going on in the diagnosis. It relies on the subjectivity of the people who are describing, subjectivity of observing, and the subjectivity of the person doing the diagnosis. So one other way of understanding why this is not a diagnosis is to think about what happens if we treated it as if it's a diagnosis. So if you said that, I've brought my son to you as my psychiatrist, and you've asked me questions, and you've said, I've explained to you that my son seems to be quite hyperactive, has trouble paying attention to their homework, and seems to get distracted, and seems to be quite impulsive. And you've said to me, oh, the diagnosis is ADHD. A legitimate question for me to ask you as my doctor is, well, how do you know it's ADHD that's causing these behaviors in my son? Well, the only answer you can give me is that you know it's ADHD because my son has hyperactivity. So this is circular thinking. This is what's called a tautology. It's the equivalent of saying that your low mood is caused by depression, is the equivalent of saying the pain in your head is caused by a headache. We wouldn't do that we would not use a description to diagnose a condition in the rest of medicine.
Now, the medical field does have syndromic diagnosis, but they do have methods to actually look closer. Just like, as you said, high blood sugar doesn't cause diabetes. It is diabetes, and it's just a objective, closer look to the problem, right? We don't know what the hell happening to the pancreas, genes, whatever, right? But there's an assumption in those cases that there is an underlying. I'm gonna go with the word entity. There's an entity that is underlying to those findings, right? Now, psychiatry is exclusively, maybe with the possible exception of dementia, it's exclusively, right? Yeah.
There are a few bits of psychiatry, or bits that still come under psychiatry, and I think correctly come under psychiatry, that do fit into a technical diagnostic paradigm, including the dementia and some movement disorders and some other developmental delays that we sometimes end up being involved in diagnosing and managing.
So that's perfect. So then we don't have a closer look, and I think we have been looking for 40 years now for biomarkers, and I don't know how many millions.
100 years at least.
100 years looking for biomarkers and even though we can make a lot of connections from a phenomenological perspective, we can say, well, if you lack empathy, you're going to be paranoid, because you cannot just put yourself into the shoes of somebody else. But that's really all in the psychological realm, not in the biological realm, as psychiatry intended itself maybe 50 years ago, when they completely divorced from psychology from DSM-2 to 3. I don't know, but so are we to think at this point, for example, I interviewed Ron Bassman, and I keep a fairly regular contact with him. Great guy. He went through a tough bit early in his life with a diagnosis of schizophrenia, admissions, insulin coma, comes out, stops his meds, takes about 2 years to think clearly again, and then goes about becoming a PhD in psychology and, work on that field for freaking 50 years or something. Brilliant guy. And his take on even schizophrenia itself, as we understand that collection, the syndromic diagnosis, that collection of things, is that there's nothing to be found, because it could very well be the reaction of a normal brain to circumstances. So I guess then my question for you in that regard would be, are we to assume, even though we don't know, because medicine frequently goes through a period where a diagnostic is syndromic, and then they find, there's research and they're successful in that regard. Are we to assume there are entities behind the syndromic diagnosis, or at least some of them, and our instruments are not good enough to detect the structural changes in brain connection, for example, because biochemistry, we have been looking for a while, neurochemistry, and we haven't found anything. Are we to have that assumption, or we should completely divorce from that assumption? Because let's say dementia, to a fair extent, as we see the syndrome, and we try to make the correlation is not good, right? We can't really say what a dementia is based on the traits. There's too much overlap. The claim that, you can tell if it's Alzheimer's or Lewy body dementia, that is not as solid as we would hope, but we have post-mortem ways to look into this thing. And in that case, we have it. Are we to completely abandon that concept, or hypothetically, we should believe there are, because all brains are different after all. They are different, right? And can you develop that thought? Can you help me? Can you guide my thought in that regard?
So, how long do we need to keep going at this? And for the, if we were a business now, psychiatry was just a business, and it keep going to the bank and asking for more and more loans, saying, we know it's there. It's going to bear fruit anytime now. And we keep blowing this money on genetic research, on neurofunctional research, on neuroanatomical research, on EEG research, and 60 years later, we're still going back to the bank and saying, yeah, it's just round the corner. How long do we carry on with this? There is, I'm not saying that we shouldn't, because we have identified a number of things in history that we originally conceived of in the psychiatric realm, and they turned out to be quite obviously organic in nature. So actually, the asylums 100 years ago, about a third of the patients in there had general paralysis of the insane, had tertiary schizophrenia. So epilepsy used to also be considered. So from time more recently, there is various types of inflammatory encephalitis, which sometimes presents with these very kind of thought disordered presentations, and we're beginning to be better at picking them up. So there is still room for us to discover certain types of identifiable pathological processes, and of course, when it comes to the brain, it's the most complex organ. And certainly, if you look at where neurology is at, it doesn't have the same degree of problems that psychiatry has, but it has a a fair amount more subjectivity than, say, a cardiologist is going to encounter. So, there are things in psychiatric science that is still amenable, and we should still keep looking for them. But if we are looking for them, I think we simply have to abandon the current diagnostic systems that we have. And I'm not the first one to say that. I mean, Thomas Insel, who was the director of the National Institute of Mental Health Research in America, the NIMH, famously in 2013 abandoned DSM diagnostics and said that we've had so many decades of research, and how much has any of that helped any patient? Zero. We haven't found anything that's turned out to be useful for clinical practice. And of course, they developed the RDoC criteria as a different way of investigating. As far as I can see, that's likely to draw exactly the same blanks as, because I think there is something that is really hard for us in our kind of being mesmerized by the sexiness of discovering things that are amenable to a technical approach with medication or machines or something that looks like space age scientific. We're very mesmerized and gullible to be looking at that, looking for things like that. But there is a deeper philosophical problem in relation to, if you might want to think of it in terms of ontology and epistemology. By ontology, where we need to ask the question, what sort of thing are we dealing with when we're dealing with the presentations that we have in psychiatry? And also, these are relevant to a lot of presentations across medicine. So, I mean, it's not that this totally sets us apart from the rest of medicine. And understanding what sort of thing helps you understand what sort of epistemology, and so in other words, what sort of methodologies is going to help you investigate this type of thing. And one of the first obstacles we have when we come to think about mental health is, what do we mean by mental health? What sort of thing is mental health? You and I know what sort of thing a fracture in the leg is. In one of the bones of the, if I have an accident and there's swelling and I can't wait there and I go to a A&E, they'll take an x-ray, they see a fracture. We know what sort of thing we're dealing with. It exists beyond my imagination out there in the external material world. So when I do trainings, that's one of the first questions I ask. I ask people, define to me mental health, define to me a mental disorder. And just think about that question for a little while. Can you escape subjectivity when you try and define it? If you can't escape subjectivity, you're into a different, you're into things in terms of interpretations, in terms of meaning. You're into the territory of philosophy. So I think of psychiatry as the medical branch of, the philosophical branch of medicine. Psychology is just a branch of philosophy, as far as I can see. It has the same problems of, when it tries to do science, it has the problems of replicability. This is bedeviling. And the fact that most psychological science is done on a small section of the world's population, because psychologies around the world have different things that have been important, different frameworks for interpreting meanings and so on and so forth. So one of the things that's really hard for us to accept in psychiatry is the phenomena that we deal with are subjective, not just in their boundaries, but in the whole parameters, the whole thing. We can't escape subjectivity. We can measure inputs, we can measure outputs. We can, have some idea of experiences and behaviors, and we can have some idea of, environmental factors. What happens between inputs and outputs? We haven't got a fucking clue. Excuse my language.
Feel free, please.
It's a big black box. And so what I think is the implications of that is that one of the things that you can say is something of a universal. There's very few things that you can say are universals about the brain, about the mind, is that it's a meaning-making part of the person. It's there to help the person, the individual organism, if you like, negotiate the environment. There's no point to a brain without an environment to interact with. That's one thing we can say. And the other thing we can say is that we're always trying to make sense. So it's a meaning making. And because we don't know what happens between inputs and outputs, what we have to bring to bear are different models, different frameworks for providing meaning for people's experiences, for people's behavior. And the models that we use are not something that should be considered accessing some sort of truth in the way a scientific model is meant, or scientific ontology is meant to get at the truth. It's meant to find something real about the nature of reality. So we can say that the person with the fractured leg bone, that exists there in reality. It's an object. It can be measured. It can be found. It can be understood in that way. But in the subjective life, all we have is models with consequences. So we're in the business of imposing models rather than discovering the right thing to label somebody with. And the models that we use will have different consequences. They'll have consequences to the individual you're working with, their family, but also at a collective level, because we are part of the process of creating cultural narratives to understand certain experiences. So in populations that have never been exposed to the concept of ADHD, for example, it literally doesn't exist. It doesn't exist because that's not part of the interpretive framework. That's not part of the cultural stories that are being told to make sense of, a person who's fidgety and not concentrating. It might be not thought of at all in problematic terms. And indeed, there's a lot of evidence that in certain cultures and in Western culture in earlier times, these were not seen as behaviors that were considered problematic, let alone problematic in a medical sense. So what we have to face up to is what we deal with in our daily work, apart from the very purely medical aspects, because a lot of the presentations we have could be down to knowable physical conditions. And a lot of the presentations we have also have physical consequences, most obviously, for example, people with eating problems. But a lot of the time, we're looking for a framework that we hope will enable somebody to make sense of their situation in a way that will be helpful to them, and that at least in the medium to long term may help reduce the level of suffering that they're experiencing.
I like very much that. And I don't know if you know this, but you're sounding amazingly psychoanalytic. And of course, I don't know enough about your training and background, but that that got me thinking to ask you the following question, because I think it can be just more. How do you work as a child psychiatrist when a family presents with a kid and he can focus and his grades are not good and he's restless? How do you proceed from there? What will be an alternative model? Because one of the conversations you and I had was in your book, you mentioned, our training needs to be rebuilt, right? And it's a fair thing. We were trained under a paradigm that didn't prove itself, so to speak, and that nice try, if you will, but it didn't prove itself. And I was describing myself on a previous conversation with Mark Horowitz. As a colleague of mine, I mentioned that story then, I'm going to mention again. I was called an activist when it comes to what I'm trying to do in the American field of psychiatry. And I said, no, I'm a strategist. I'm trying to do the doable so we stop hurting people, right? And because one of the resistance that we face, of course, is not only the fact that this challenges a paradigm under which people were trained, we also face as a challenge the fact that people will be resistant to it because what does that mean? What do I do? I'm a prescriber, right? That's what I do. I throw drugs at people. Now you're telling me, there's no even diagnosis. And so I guess the simplest way to address this thing will be with ADHD as you started. And later I want to ask you about another thing that you said in your book that I loved it. You describe diagnoses as brands. But how do you handle in your clinical practice? Because I know you are very active professionally.
I get asked this question, and I've always found it hard to answer that. I remember being interviewed by somebody in relation to a project that they were doing, and she kind of kept drilling me on this. Come on, tell me what you do. And I was saying, well, it depends on what the family is, because I'm trying to find a model, a way of thinking, a way of working that might make sense. So one family, I might be talking about how to deconstruct diagnosis. The next one, they've already got a diagnosis. That's part of their cultural way of imagining and understanding. So actually to start helping them, just reimagine diagnosis and think more in formulation terms might actually feel insulting, And she kept going on. She said, yes, but, I get what you're saying, that there's something intuitive that develops. And she said, people who play golf, they develop a swing and they can't describe what it is that they do, but they can tell you how you might go about developing your own swing. So how would you tell me to go, So she kept persisting. But actually it's a very hard, because once you step out of that diagnostic framework, you're stepping into a different paradigm of working. You're stepping into a more context-rich, relational paradigm of working. So you're trying to, one of the things that I think has influenced, my practice has been influenced by many different things, including different trainings. I have had a fair amount of psychodynamic training in my background, but also family therapy. And then the more so-called postmodern therapies like solution-focused and narrative therapies. And so they are all become somewhere part of the models that you can draw on. And the way I think of it is it's a bit like, the old-fashioned films where they have the doctor and he comes with his bag of tools. So I think our bag of tools is it's mainly our voice. It's mainly the different models that we have. So my bag of tools is the different models that I have. But any good encounter involves being able to respond in the moment, in the here and now, to the people that you're working with in a way that feels genuine to you and genuine to them. So there is something about being open, curious, and responsive in a clinical encounter, rather than coming in always with knowing it's good to come in with your models. And this is one of the problems if we start to practice diagnostically. So when you diagnose diabetes, your treatment is aimed, understandably and logically, and for the right reasons, at reducing glucose. In other words, reducing the thing that you're considered to be the pathological problem that you've diagnosed. Yeah. But unfortunately, that becomes the logic when you go down the route of, say, treating somebody who has, let's stick with your example of ADHD. The idea becomes you're providing treatments in order to reduce these behaviors, these particular behaviors. And it's already focused your idea that there is a problem here in certain ways that this person is behaving, and that the therapeutic task now and the framework that I'm going to use is that I have to provide a treatment that does something to reduce the presence of these problem behaviors, which we're calling now symptoms. But that then leaves out a whole sets of dimensions. Maybe these behaviors actually aren't the things that the person is mainly struggling with. Maybe they're actually doing quite well, but the things that's really an issue for them is that they're getting into trouble at school a lot, but at home they're, their parents know how to tolerate this and know how to. Maybe they've got some sort of food intolerance. Maybe they've got some undiagnosed particular learning difficulties. Maybe there's a history of trauma that's got in the way. Maybe actually there's not much going on here that's wrong, but people are missing what this kid is good at. And so it's kind of a self-esteem problem, because they keep noticing that he's not good at this, but he's actually brilliant at, on the Xbox, he's got an incredible level of concentration he can achieve. So he's got, and so maybe just a strength-based approach, helping people notice and celebrate and be joyful about and see value about all the good things that this person brings. So I'm not answering your question in a straightforward way, because what I'm saying is you need to have that flexibility and imagination. And by the way, this is not an anti-medication stance either, but it's understanding that the medications we use have very generic effects. And those generic effects are mainly short-lasting. They're not that powerful for a lot of people. So particularly SSRIs. I mean, SSRIs are close. They're not in a substances, because you can become dependent on them quite easily. But in terms of their effects on, particularly in childhood depression, I mean, there's no real difference between them and placebo. I mean, we've been investigating this for a while. However, sometimes I do prescribe, and it's largely because there is this pressure from the person, the family, or the teachers, or people who've been telling them, because this is such a widely held narrative in the public. And so when I do, I think of it in much more strategic terms. And if things do improve, it's always important to point out to people that a medication can't have a thought, and a medication doesn't initiate an action. It can sometimes maybe be a bit like the oil that helps the wheels turn a bit easier, so that you can if you're using a diagnostic paradigm, you will miss agency. But the thing that might lead to more long-term improvements is helping the person reconnect with their agency and see that it wasn't some magic pill that helped them improve. It was what they did, how they thought, the support they had. It's the changes that they were able to make. Those are the things that are going to be more long-lasting.
I understand. I think actually you answered, and not surprisingly, you started the conversation by describing psychiatry or medicine in general as an art or a craft, as you said, and then of course you emphasized the role of philosophy in this picture, where and then you talked about meaning and finding the meanings of things, and taking that sort of knowledge into consideration, as opposed to coming from okay, let's just see where you fit here, and if you fit in this box, then I have all this chemicals to throw at you, and I kind of understand. I think I got your answer, maybe better than you thought it would come out. So I have to say, though, I would assume, obviously, you see a huge role for psychology or philosophy, if you will, but in our field, psychology, in terms of training and this more inquisitive take to presenting problems. Am I right about that?
I think it is important, and what I would really like to see in our training is helping people develop their critical faculties, their capacity to think on their feet, their capacity to tune into relational aspects of care, their ability to draw on different models of understanding, so that they can be skeptical of all models, as well as see what use they might be able to get from them, so that they can treat the models that we have as models, not as the truth in any way, so that they will loosen their attachment to this particular way of viewing, and particularly loosen their attachment to a diagnostic model of care, because I think some models are worse than other ones, rather than some models being better than other ones. Models that might introduce the person that you're working with to an idea that they have something wrong in them is likely to have a much more long-lasting effect on that person. Because if you've, for example, conceptualized their depression, their unhappiness, their suffering, their misery is to do with something that has gone wrong inside of them, some disorder, some dysfunction. And formal psychology is often just as bad as psychiatry at doing this. So, like, for example, one of my pet hate concepts is the idea of emotional dysregulation. I don't know what the hell of emotional regulation is. Seems to me like an oxymoron. Emotion is emotion. It happens, So, so psychology, formal psychology, can be just as guilty as formal psychiatry in creating an idea that there is something wrong in you that requires us, almost like surgeons, to sort of delve in there and correct your incorrect way of thinking, correct your incorrect way of feeling, and get rid of this depression tumor that's that. And one of the one of the long-term implications of that way of thinking, of that model of intervention, and this is not in an absolute term, but a tendency, is that it can lead to the person being set up by accident to a potential lifelong struggle with a sense that there's an aspect in them that they have to keep under control. And if they don't keep it under control, it can raise up, you know, a bit like from your biological unconscious and take you over every now and then. And you have a lifelong struggle trying to keep this part of you, which is wrong, which is faulty, under some sort of control, because especially if you can't get rid of it. Now, I'm not saying that that's a thing that will happen to everybody, but it's a tendency. And I think it's part of the explanation as to why we seem to have rising rates of people who are categorized as long-term mentally ill. That's happened across societies where there has been plentiful mental health services. I know some people like Robert Whittaker put that down to the medications we use, and I think there's something in that. But the pathway to using medication in that manner is diagnosis. It's the concept that there is something abnormal. Whereas if, from my point of view, the people that I see walking into my consulting room, very rarely do I see people who I feel there is something wrong in them. They're experiencing suffering. Suffering is a meaningful human experience. If you turn it into something that is, if you like, meaningless chemicals going around in your brain that you need to suppress, you've turned a potentially awful but meaningful human experience into meaningless torture. You can make something that you might actually get value out of, not necessarily, or even just some increase in the depth of your understanding of your humanity, into something that's kind of superficial and just needs to be get rid of. In fact, if you see a lot of culture, particularly Eastern cultures, suffering has a very important place in deepening your understanding of the human condition, or often conceived of as part of deepening your connection with your spiritual life. But for me, it creates a different meaningful framework. So for me, the people that I see are people who are generally reacting in ways that I might not understand, they might not understand, but it is within the realms of the way human beings are built. In a very simple way, when bad things happen to you, you feel bad. And there's all sorts of ways you can extend that.
Very fair, and I think I'm following your thought, and it makes absolute sense. One thing that I frequently say, I have a mentoring institute where pretty much what I do is, look to psychiatry with a critical view, and discuss alternative ways of handling things and for the most part minimizing damage. But to an extent, I would expect you to almost have to work on a subversive way, because I don't know how the health system works in the UK, but in the United States, you have to assign a diagnosis, and and we also have the concept of standard of care that I think it's something that holds back this more artistic and a search for meaning approach to the care in the field of mental health, if you will. Because at the end of the day, people fear to be, caught into litigations and things, and they have to document their actions in a way that looks like they're doing the usual stuff. It doesn't matter how bad the usual stuff is, because of this freaking concept of standard of care, because the standard of care is, if your patient's not taking at least 5 medications, then you must be doing something wrong. Of course, not declared like that, but when you look to the average patient or people out there is struggling with life. They're taking one medication of every thinkable class out there, and still, miserable. And now we create a whole new market for statins and hypoglycemiants, among other interesting drugs. I think from there, I would ask you to go back to that topic on describing diagnoses as brands. Do you mind exploring that for our listener?
Yeah, of course. I mean, just briefly, what you're saying about being subversive, it is strange, because in many ways, I think the things that I'm saying, most people who work in mental health are actually sympathetic to that. In some ways, I think psychiatry is becoming the outsider, even though psychiatry still has that enormous power. I think there's a lot of those who are in the mental health field now who are looking at the way psychiatry and diagnosis and excessive use of medication, long-term use of medication. As I say, I'm not against medication, particularly in short-term use, and saying this doesn't make sense. This is not scientific. It's sometimes inhumane. It's, so in some ways, I think psychiatry is becoming a bit the outsider. But I've found all sorts of tricks that you can use to get round systems over time. But maybe it's easier for me because I work in the National Health Service, and so it's not about insurance reimbursements, but National Health Service has its own systems, which includes, doing diagnostic codes. But there is no sort of financial penalties in the same way. For example, the way we organize care at the moment in child and adolescent is we have what's called care pathways. And there's nine care pathways, and they're sort of broad diagnostic, so there's a depression care pathway, there's an anxiety care pathway, there's a social anxiety, there's an attachment. And I just ask my secretary, just put whichever one you want, put them on whichever pathway you want, it's that kind of a subversive thing. And fortunately, the team I work with, we don't take these things seriously. We think more about what might be helpful. But the question of brands really relates to how these things now operate in the cultural life of our society. We live in societies that are economically structured through the idea of markets, and that markets organize the things that people want and need. It's a very particular way of imagining how an economy works. But behind each imagined economic system, there's also an imagined way of what we think of as how humans work. So famously, markets are built on a kind of neo-Darwinian idea of humans, that the best way to organize human societies is to create a competitiveness between them, and those who are more capable will rise to the top, leaving others who are maybe considered less capable. And in a market economy, the less capable to try and soothe the guilt of those who have developed this system and are doing well out of this system are given labels such as vulnerable. So we think of them as vulnerable and kind of needing extra care. So we have a system in a market economy which puts people into what I call a compare and compete situation. That's how that's how businesses work. They have to compete and then look at their competitors and think what they're doing and if they can do better. And it's not surprising that that value system filters around into everyday relationships. So you see this in school children who very much are quite concerned about how they look, how they come across, how they feel. So it's a very judgmental culture. So it's very easy to feel yourself being on some sort of loser side of the equation in the competitive world. But also, if you feel yourself to be on the winner side of the equation, you're always looking all over your shoulder and wanting to identify the loser to reassure yourself you're not in that class. So this in itself creates a demand for, because this is tough on people's psychology. So it creates demand for mental health. And in a market economy, what then comes in is these diagnoses, and they offer themselves as the vehicle through which you're going to feel better. You're going to understand, or you're going to get the right treatment, or you're going to get the intervention. And so how they operate in their real life in our culture is the equivalent of brands. So what you see is the brands with high demand become very prevalent in our conversations and develop all sorts of products. And the things that have a high demand in our culture are managing behavior problems in children, and that tends to be mainly aimed at boys more than girls. And then managing depression, anxiety, and concerns about the self as you go through adolescence and into adulthood. And your main audience there, your main customer base is females and women. And so the brands that you see that have grown enormously are things like ADHD, autism, depression, bipolar disorder, and recently borderline personality disorder has, I don't know if it's the case in the US, but in the UK, that one has become, has grown enormously. And what you'll see in successful brands is they start to find new markets. So autism and ADHD were classically childhood diagnoses. They originally started off as fairly rare. When I was first training in child psychiatry in the early 90s, autism was hardly ever diagnosed. It was considered a rare condition. It was Kanner's criteria. It was like, you know, in my whole of my 4 years training in child psychiatry, I saw 2 young people, and they both had moderate learning difficulties, you know, were clearly had significant challenges. And so not only have you seen them expand, so that's a good example of what happens to a successful market. So it grows experts, therapies, books, programs, research institutes, you know, a whole swathe of products starts to grow around that brand. But then it starts to export beyond childhood. So adult ADHD and adult autism. And as you move into adults, the consumer base starts to shift too. So the thing that's really growing in this country, and there's been some recent research that has borne this out in numbers, is adults who are getting diagnosed with autism and adolescents. And unlike in childhood, it's women who are the main expanding customer base. And you see that with adult ADHD. Conversely, with depression and bipolar disorder, we've seen an expansion of that from adults. Was when I was training. The books, the psychiatry books that I had on childhood depression talked about it as a very rare disorder associated with severe trauma or abuse, and not amenable to treatment with pharmacology. Well, that all shifted. So childhood depression became one of the most common disorders we make. So that's what a brand looks like. Now, there are other diagnoses that we have that are not as strong in developing a market. They might still have a market amongst some professionals and so on. But when you look at these patterns, you see that they are following the patterns of brands. They have created a strong consumer demand for areas in our culture where people have a lot of anxiety and are looking for something.
Would you say the main a factor pushing that expansion is the availability of brand new medications, like under a brand? And by brand I mean brand names, like patented, because now we have a drug for this and this is brand new and we got to expand the use of it. Thing like happened to so many. I mean, we have still a lot of medications under patent for ADHD. A lot of Abilify came for behavioral problems of autism, approved by FDA. And but if you agree that is a driving force on top of cultural factors, and that it also probably influenced by this sort of advertising, and of course, I think everyone I know would like to know why they haven't done things better in life, in a sense. But when you have a diagnosis, that's why, right? That's kind of, as you say, more diagnosis, less agency. I think that will lead me to probably my last question: why it's so hard to have these perfectly sound ideas that you're sharing make through the heads of our colleagues? Why do you think the field just doesn't put any thought into it? Why do you think we're so easy? Why our field ended up having the same diagnostic skills as the diagnostic skills of someone who reads Google?
Yeah, that's a good way of putting it. And in fact, I suspect you have a similar thing in your practice, that people come and say, I've been looking this up and I'm convinced I have a bipolar disorder.
Which is frequently confirmed by the previous provider.
Yes.
That's the concerning thing that I have. There's no expertise anymore.
Very easy to go down that route, because to me it's a bit like reading your astrology chart. The things that you read are so subjective that if you're experiencing certain issues, you read this list and you think, oh my God, that now it makes sense. Yeah. This is, but isn't selling in a market economy all based on that? The promise. In order to sell your product, you need your audience to have at least some degree of dissatisfaction of certain aspects in their life for them to say, oh yeah, this would make my life better. There are powerful forces in a market-based economy. If you have the money, you have the influence. You mentioned the pharmaceutical industry. Of course, that's the second biggest and most influential industry in terms of lobbying, in terms of buying power. It comes after the military-industrial complex. So, I mean, we're up against people who have money, who have power, who have clout. But also our institutions, the Royal College of Psychiatrists in the UK, the American Psychiatric Association, and I know many good psychiatrists both in America and in the UK, who are members of I'm a fellow of the Royal College. I sit on our Child and Adolescent Executive Committee faculty, although I don't know how long I'll stay there because I'm making a few waves that made some people feel uncomfortable. But, they talk to me. So it's not that they're not good people, but once you have these systems in place and care is organized around these concepts, it's very hard to shift it. However, there are a few things that make me think that it is important that we carry on these conversations, that we carry on having these discussions, and that we carry on talking about these things. So the World Health Organization last year produced a new set of technical directives, which were very much suggesting that we need to move away from the dominance of biomedical models of care. The special rapporteur, Daniel Purias, he's now moved on to his next, at the United Nations, has also written about the human rights and suggested that mental health care needs to move away from coercion and biomedical dominated models. So there are lots of places where these things are happening, and you don't know. I mean, the publication of DSM-5 brought huge amounts of protests from many institutions, many organizations. They haven't gone away. There's a big service user movement. The Mad in America website brings together I'm part of several groups who have critical perspectives of various types. And you don't know when the point might come where there is enough of a critical mass for something a bit more profound to change than the kind of incremental changes that happen within a paradigm. I'm sure you're familiar with the work of Thomas Kuhn, who talked about changes in scientific thought and the importance of the framework that is being used to interpret the findings. And he used the language of social change. So he talked about scientific revolutions, not change or discovery, that every now and then the results cannot be fitted into the dominant interpretive paradigm. But those who stick onto the paradigm keep trying to find ways to claim that they can. And eventually, a younger generation comes along who are not so caught up with this. And at some point, what he calls a revolution happens. More and more people stop using the old model because they don't see it fit for purpose. And the other model that has come along becomes dominant, becomes hegemonic. So I think that, that those changes that result in paradigm shifts are kind of quite a profoundly political thing. And as we see in our politics in the world at the moment, you just don't know when something profound is going to start shifting. You had the whole Soviet bloc. Nobody predicted that it would sort of start dissolving in the way it dissolved. And when it started dissolving, everything changed very quickly. When 18 people sailed to Cuba back in 1962 or whenever it was, nobody could have foreseen those 18 people would eventually result in an uprising that brings a government into power that's still there today. You don't know when that critical mass will be enough, how it will work. So the thing that gives me hope is I know from talking to a lot of people and being involved with a lot of different organizations that there's quite a big number of people out there, and it does get into the mainstream media every now and then, who are pointing these things out, and the mainstream doesn't really have an answer. Eventually, that will be found out.
That's very encouraging. That's the feeling I've been having. I even asked that to Dr. Moncrief when I spoke to her, saying, hey, I have this feeling. Is it just me? Because now I'm, kind of reaching all these folks. Anyway, Sami, it was a pleasure talking to you. I would really hope we would have another chance, to have a chat. I probably have more questions for you, and we explored some of them via email. Again, thanks a lot for accepting our invitation.
Thank you, Rod.
It was a pleasure.
This podcast was offered by anypmi.org.